to talk mainly about the different types of MRIs we do for the UW ADRC and the different researchers do for their projects. We heard from Tom that MRI really only plays a role in looking at hippocampal atrophy and cortical thickness. But I hope I can convince you that MRI can be a lot more exciting to just understand the complexity of AD, not so much in its diagnosis. Everyone here probably already knows that AD it's a very complicated disease. And we know that amyloid and tau are the etiological drivers of the disease. They are, we can measure them with PET, not with MRI. But in the disease, we also see abnormal cerebrovascular disease. So we see abnormal blood vessels, blood-brain barrier breakdown. We do see synaptic loss. There is an increase in abnormal immune signaling. Genetics matter. We all know about ApoE and presenilin genes that increase the risk for Alzheimer's disease. We do know that Alzheimer's participants can have, or patients can have, comorbidities like alpha-synuclein and TDP-43. And also there are many risk factors for AD, like exercise, lack of sleep or poor sleep, and poor diet. So these are all factors, some of them leading to Alzheimer's disease, some of them being a downstream effect of amyloid and tau deposition. So it becomes, when an individual comes to you, it is really hard to tell what stage they are at. And that is what is the challenge for Alzheimer's disease. And just in brief, we know that Alzheimer's disease cases are on the rise. There will be about triple the number of cases we have now by 2050. There is no good standard of care to test the general population. So Tom showed the ATN classification, and one of the motivations was to use it to understand who could develop cognitive impairment, who could develop AD. You could now go to your PCP, do a basic metabolic panel, every few years and know your risk for some of the diseases. But there's no such test for Alzheimer's. You can't get a PET every few years. This is actually where the plasma markers are really exciting. If they do pan out, we can test for risk for Alzheimer's maybe. There is no treatment to stabilize or reverse the disease processes, especially the neurodegenerative processes. So when Tom showed the hippocampal atrophy in MCI and dementia, that it actually predicts progression, but we cannot reverse that atrophy. So sometimes, in sci-fi shows, you will see a blurry license plate, how they can easily clear it up. It's completely against Shannon's information theory. So it's similar here. You have a hippocampus that's atrophying. You cannot reverse that atrophy. And we want to find markers that or methods that can help us detect Alzheimer's and disease processes before that degeneration occurs. Currently, what we can do is use some disease modification and find targets for this disease modification. And then here I put down precision medicine as an approach to treat Alzheimer's, also for disease modification purposes. Primarily for two reasons. One, it has been very successful in cancer, but also because precision medicine in Alzheimer's was kind of central to the UW ADRC. And the idea of understanding an individual and where their disease originates is kind of core to all the research that we do here. And that includes the clinical core, the neuropath core, imaging core, all the cores together. But so far, precision medicine has not been very successful in finding a cure for Alzheimer's disease. So to give you an example, if we compare it with cancer, typically you will have about 3,000 to 4,000 drugs in cancer that are made every year. About 28% of those are related to cancer, and maybe 2% are related to AD, and they're not all really significant. So yes, coming back to this slide, the reason for that is probably all this complexity in Alzheimer's disease, how the disease originates, how it progresses. People just have different trajectories. And I think that is where MRI plays a really important role, because it can help understand different aspects of this complexity and different pathways. Because I think MRI is very versatile. So it's one modality, but you can get so many different features of the brain from the same modality. And here I'm showing pictures of some of the MRI techniques that we work with. So T1, Tom showed us how we can use that to look at cortical atrophy and then also hippocampal atrophy. A T2 and a T2 flare. These are typically used to look at enlarged perivascular spaces. You can also use them to look at white matter disease. So these are white matter hyperintensities here. You can try different types of MRIs. So this is diffusion MRI, and that helps you look at nerve fiber pathways in the brain. So how are different regions in the brain connected and how are they affected in a disease? This is perfusion MRI that helps you look at blood flow to the brain. And maybe that's not only it. The blood flow might be different, not because of Alzheimer's pathology, but because of a vascular pathology. So you have angiograms where you can look at large vessels. Similarly, you have susceptibility-weighted imaging that looks at the venous side of the circulation. You can look at myelination of the nerve fiber tracts. You can also look at functional MRI, which tells you which brain regions kind of talk to each other and make your brain function normally and what happens in case of disease. And this is the synthetic MR that Tom mentioned, where in 6 minutes, you can get T1, T2, flare, you can probably derive a SWI from it, and you can get a myelin water fraction map from it. So all this is possible through just using an MRI machine. So I'm going to go through a lot of different techniques, and I will put the picture of the technique in the corner. And I'm trying to highlight some of the new things that are being done at the UW ADRC and by the ADRC researchers here. So we saw that cortical thinning has a typical pattern in Alzheimer's disease, and then there are 2 other patterns related to limbic atrophy and then hippocampal sparing. Here, we are looking at a cortical thinning pattern that is related to a relatively new biomarker called NFL, which is neurofilament light chain. This is a marker that's present in large myelinated axons. And it's well established that higher the CSF NFL, you have more atrophy in the brain. So that's great. But here what we've shown is that a baseline level of neurofilament light chain can predict over 3 years what the cortical atrophy pattern looks like. And this is not an Alzheimer's pattern. MRI is not a diagnostic of AD, but it gives you other information. And this is a classic example of that. What we are seeing is mostly frontal higher order association areas that are atrophying over time. These are the areas that develop latest in people. And these are the areas that we are seeing with NFL are the ones that are atrophying over time. Here I show another study, which is actually in dementia of Lewy body. So this is more ADRD, where you can take the T1 and instead of just looking at hippocampal atrophy, you can look at the atrophy of specific subfields. Because hippocampus is atrophied in Alzheimer's, it's atrophied in Parkinson's, it's atrophied in DLB, it's atrophied in schizophrenia. So now we need to go delve a bit deeper. And we've done that here with this hippocampal subfield segmentation. And for dementia of Lewy body, we looked at MoCA and UPDRS. Our goal was actually to see what subfields of the hippocampus are really associated with cognitive functioning. And we didn't expect too much of an association with UPDRS. But what we found was that this C3 region, there's this hippocampal amygdala transition area, and a few of the medial regions of the hippocampus that were associated strongly, the atrophy was associated with poor MoCA scores. We found a really poor model, but we did find that the body of CA1 and this cortical nucleus here were associated with UPDRS scores. And when we looked further, actually, we don't have the results here to show, but this cortical nucleus is connected to the olfactory cortex, which is very prominent in Parkinson's disease and is associated with poor motor symptoms and UPDRS scores. So just delving deeper into the hippocampus gives us some way of differentiating between diseases and between different cognitive profiles. This was all about gray matter. We can also look at white matter, and for that, we are looking at T2 flares or T2 weighted images. And white matter injury or white matter hyperintensities They're actually not a marker of Alzheimer's disease. They're a comorbidity. They are a gold standard for cerebrovascular disease, but they do predict worsening cognitive outcomes. And the interesting part is you can see in the background, I have a FLAIR image with white matter hyperintensity. They're only visible on this T2 FLAIR MRI. If you look at a postmortem brain and look at the MRI, you will not see the hyperintensity there. So they're difficult to study. And what do they really mean? People have hypothesized, many researchers have worked on hyperintensities, and they think that they can have a vascular pathology. So there might be less blood flow. There can be neuronal pathology. So there's an injury to the neurons in that area. There could be inflammation and fluid because they're close to the ventricles. And a lot of times the lining of the ventricles is damaged in disease. So you could have fluid pushing in on the neurons. There are lots of mechanisms that can cause these hyperintensities, but no way to test them. So we did a preliminary study in about 54 adults, relatively cognitively normal. A few of them had mild cognitive impairment, and pretty standard with cardiovascular parameters. In this study, we used 4 different types of MRI. So you have the T1, you have T2. The T1 is just to understand the anatomy of the brain well. The T2 is to look at white matter hyperintensities. The DTI to look at fibers, and ASL to look at blood flow. So what we tried to do is, this is a cartoon representation of the brain. And let's say that this blue is a white matter hyperintensity. This is from the FLAIR image. From the T1 image, we identified different cortical regions. So here I've depicted them with this dark blue and dark green color. And then we kind of made these regions as the source and target for the DTI algorithm. To find which regions are connected to each other and which of these neuron fiber tracks actually pass through the white matter hyperintensities. Finding these, then we can go back to these cortical regions and see what is the pathology there. Are they atrophied? Do they have poor blood flow? So that's why we have the T1 and the ASL image. Now this could tell us, is the white matter hyperintensity affecting, is it affecting these neuronal fiber pathways? Or are these pathways, many of them could go through this white matter hyperintensities, causing the white matter hyperintensities? But this is still just a cross-sectional one-time point study. And here, what you see in one brain is an individual brain with different colors showing different regions of the brain, and the blue dots showing all the fiber pathways in the brain that are passing through different white matter hyperintensities of this individual. And we did that for all the individuals. And what we found is that there are, of course, more white matter hyperintensities in MCI, but there's also a higher overlap of these pathways and white matter hyperintensities. We also found that most of these the pathways that are disturbed are ipsilateral. So left-sided connections are affected and right-sided connections are affected. Very few interhemispheric pathways are affected by white matter hyperintensities. So that was interesting. And there were about 35 tracks that we found were affected in these people out of 286 total fiber bundles. And these tracks were mainly associated with the striatal regions and thalamic fibers. And they could give us some clue about maybe the motor symptoms or gait problems that older adults have, but not so much about memory problems. And these could be things that worsen cognition over time, although it's not related to Alzheimer's disease. This just shows which of those were significant in the end. So the next step was to look at the cortical regions. Now, the cortical regions that were affected through that nerve fiber path, if we look at their cortical thickness here, in black, I'm showing the thickness of controls, so normal cognition, and their nerve fiber pathway was not affected by white matter hyperintensity. And I'm showing this for one particular pathway that is kind of goes from front to the back. So it's a cingulate to precuneus pathway. So not ipsilateral, but something that's more relevant to AD. The black hatched column is controls in whom this pathway was disrupted by white matter hyperintensities. Yellow are MCI participants where this pathway was not disturbed by white matter hyperintensities. And the yellow hatched is the same pathway again, but now disrupted by white matter hyperintensities. And what we see here is a very nice decrease or atrophy in the cortical thickness of these regions with diagnostic status and with the knowledge of whether they have, whether that path has been disrupted by white matter hyperintensity or not. And then this also applies to blood flow. Actually, in blood flow, we had some significant differences, not just a trend, showing that blood flow not only decreased with cognitive status, but if you had white matter hyperintensities obstructing these paths, then the corresponding cortical regions had lower blood flow. So this, you can have like a pie in the sky question. I have a white matter hyperintensity. I can find exactly what regions of the brain are affected, that the cortex is thinning, they have poor blood flow. Can I ask the question, can I build a white matter hyperintensity based individual cognitive profile? So it's taking it even further. And now we are looking at our first attempts to answer that question, which is to take that track, and knowing that this track is affected in logical memory, we looked at all the individuals in whom this track was affected. We found out how much of that track was disrupted, and then their memory scores. And what we found was more the track was affected, poorer was their memory score. This track is not associated with semantic fluency or verbal fluency. So when we look at that in comparison with semantic fluency scores, we don't see such a relationship. So we can start getting really specific based on that person's hyperintensities and location. This is still at a group level, but it's our first attempt to now associate mechanisms, white matter hyperintensity, and cognition together. So because white matter hyperintensities are vascular disease, we need to understand what are the vascular measurements that are related to white matter hyperintensities. And so here I'm introducing you to another MRI modality, which is CVR, and Tom briefly spoke about it. This is a fMRI or functional MRI technique that in which we manipulate the gases that you are breathing. So now at the DISC facility, we have this device called a Respiract. And as you can see here, this is a gas tube that goes into a breathing mask that the participant wears, and then they go into the scanner. In the scanner, we modulate the amount of oxygen, carbon dioxide, nitrogen that the individual is inhaling. And with increasing carbon dioxide, you do see the vessels dilate and there's increase in blood flow. So that allows us to check, are the participants' blood vessels able to dilate? Are they patent or have they gone brittle where they don't have the ability to dilate and increase blood flow in the setting of really low oxygen and high carbon dioxide? So this is kind of the setup. You see the gases. This is the computer that is outside, which we program to deliver the carbon dioxide and oxygen in the concentrations that we want. This is the device here, and then the mask that goes into the person. And here you'll see in blue is the trace of carbon dioxide that the person was breathing in. It's a sudden increase in carbon dioxide, and we taper it down. We hold it steady at normal levels of carbon dioxide in the air. We reduce the amount of carbon dioxide, increase oxygen, and then we start another challenge with carbon dioxide along this ramp. And then the bold signal, the MRI signal, very nicely follows this pattern. If the blood vessels were not healthy, they were not able to dilate, then we would not see such a pattern. So we use this phenomenon to also understand what could be causing these white matter hyperintensities. And so here is one of our earlier studies, not using the RESPRAC, using just a breath hold to increase carbon dioxide, but to calculate CVR in about 50 individuals again, and blood flow. And this is a map of their hyperintensities. The red shows regions where almost everybody had hyperintensities, and blue shows regions where very few people had hyperintensities. And what this graph here shows you is inside the hyperintensity, you can see the blood flow in blue and CVR in red. And then we mapped both the parameters about 1 centimeter or 10 millimeters outside the hyperintensity. And we see that the vascular reserve, CVR, is completely exhausted in the white matter hyperintensity. So in these regions, if those neurons need more blood flow, more oxygen to work, the blood vessels there simply cannot do that. They don't have the ability to do that. And they are at 50% of their normal perfusion level. So blood flow is low and CVR is completely exhausted. And as we go out to normal tissue around 1 centimeters, you have normal blood flow, normal CVR. So then the question is, can we predict just outside the white matter hyperintensity, these regions where we have low blood flow and low CVR, can we predict that this is where the white matter hyperintensity will grow? And if that is true, can we do something to increase the CVR or increase the blood flow and prevent the hyperintensity from growing? And for the sake of completeness, we are talking about vascular pathology and vascular disease. How does that relate to cognition and Alzheimer's? So here is a study in our ADRC participants, the 91 participants that Tom showed at the end. We did perform a CVR challenge and a blood flow MRI on those participants. And here we see that the CVR in the posterior region was associated with AD biomarker burden. So if you have more AD pathology, you have poorer CVR. And that's what you see here in the posterior regions. And this was true of everybody, whether you have mild cognitive impairment or not. If you look at cognition, then in controls, individuals who did better had higher CVR in the frontal cortex. We didn't see that relationship in the MCI population. For blood flow, we didn't see any correlation with cognition, although there are many studies in the literature that show that, but we do show that there is a relationship to biomarkers. So higher the AD pathology in the brain, lower is the blood flow. So some other studies that are going on using blood flow is what I'm going to discuss next. So this is work by Dr. Angela Hansen, and she studies high-fat diet as a risk factor for Alzheimer's disease, and also how this is mediated in ApoE4 carriers. So as we all know, E4 plays an important role in cholesterol transport and lipid transport. So she's trying to look at E4 carriers, non-carriers, and how they react to high-fat diets. Now you can do lipid tolerance tests and assess lipid metabolism in the body, but it's very hard to get a measure for just the brain. And so Angela decided to use blood flow as a surrogate marker for metabolism. And she's conducting this study where people have a high-fat diet, and then they get imaged immediately after they have the food and in 4 hours after they've had their high-fat drink. Last time when I presented, I showed that with E4 carriers, you do see a decrease in blood flow at the 3-hour and 4-hour time points after they've had a high-fat diet. This decrease is much larger than a high-fat diet in a non-E4 person. Now this time she's extending this into looking at hypertension. And what we find is that after a high-fat diet, blood flow in an individual with hypertension is very, very low compared to a normal person. And these are two individuals, both non-E4s, 70-year-old females, that are age and gender matched. Just the left image is that of an individual with no hypertension, and then the right is an image with hypertension. So a very striking difference, and she's going to present it at AIC this year. So now I would like to move on to another technique, a very simple and a very popular technique at the UW ADRC, which is fMRI. And fMRI is based on the oxygen levels in the blood. So what happens is in the brain, if we assume the brain is at rest, which means there's minimal activity, there's blood flowing through blood vessels. These are neurons, they are firing, but minimally because you're not doing any conscious task, and our blood is delivering the necessary oxygen to them. When you do a conscious task, then the neurons start firing more, they need more oxygen, and to supply that oxygen, you see an increase in blood flow. And to increase that blood flow, there's an increase in blood volume as well. All this results in an increase in oxygenated blood to the region of the brain that is active, where the neurons are firing. And that changes the magnetic properties of blood, which it becomes more diamagnetic. And what that means is it gives you a higher MRI signal. So if you collect these fMRI images over time, where your neuronal activity goes up and comes down, you can see a similar pattern with this oxyhemoglobin signal, where the MRI signal kind of follows the neural activity, goes up, and then again comes down after some time. The very first study was done with a simple motor task. And this picture A, the red A, shows the brain regions that have an increased fMRI signal, a bold signal, after a finger tapping task. And you see very nicely that it actually shows the somatomotor cortex and the supplementary motor area. But what Bert Biswell did in the 1990s is he decided to collect the same sequence without asking the participant to do anything in the scanner. They were just lying in there. And then he took this region A and he said, let me see what this region looks like. What does its MRI signal look like? The brain is not really at rest, it's doing something. So is it really communicating with any other brain region? And yes, it is. It was actually connecting to the right motor cortex and to the supplementary motor area. So you could get almost the same network of regions that you got with a task. And these regions are talking to each other at rest. Not all regions are talking to each other. So here's an example of the motor cortex connected to the visual cortex, and you don't see too much correlation between them. So at rest, when we are not actively engaged, the brain regions are still communicating with each other. That's how we have our consciousness, our awareness, and also how, in general, our attention and memory is consolidated over time. The brain regions are still working. And this leads to distinct resting state networks in the brain. So here I'm just showing you a cartoon of some sample networks. So you have the motor network that I showed earlier, two visual networks. There's a salience or insular network, and then there's the parietal frontal networks, the default mode network, and the frontal or the executive network. So all these brain regions are talking to each other. Within each network, they're talking to each other, but these networks also communicate amongst themselves. And we can assess this complexity with fMRI. So here I'm showing you the fMRI results from about 100 subjects, where we could identify at rest that the brain went through 8 different states. And in each state, it was different brain regions were talking to each other. The pattern changes. What you see here in these matrices are those connections. Red means that those two regions were really highly correlated, were really talking to each other. And blue means they were anti-correlated, so they were doing opposite things. And you can see that the pattern changes in each state. So these 8 distinct states, we took them and then we said, how do these states look in a normal person versus an MCI person? And what we found is that state 4 and state 6 transition to state 3. And this transition was less frequent in MCI participants. If you look at these two states, they have the default mode network and the frontoparietal network. They're highly engaged in state 4. Frontoparietal network is highly engaged in state 6. They've kind of disengaged in state 3. That stage is not occurring in MCI participants. Now, this is very useful because the default mode network, the frontoparietal network, they are all associated with memory performance and for consolidating memory. So, and also for attention. So they do make sense as to why this, so we detect this kind of abnormal transition in MCI participants. Another state difference that we found was between state 2 and state 7. So this is again, big difference with how the default mode network connects with the rest of the regions. Sorry, state 2 and state 7. So how the default mode network connects with the frontoparietal network and the dorsal attention network. So this is again, the connection between frontoparietal, dorsal attention, and default mode network is very well known to be affected in Alzheimer's disease. And now we can see how that connection is being abnormal in a person. I'm going to switch topic again, and I apologize for continuously switching topics because there's just so many MRI methods, and I want to give them all to you like a menu card, so then you can think of ideas and then come to us with many imaging projects. So Jeff is on the call, and I don't want to go too much into this, but I just gave a brief idea that the glymphatic system, we consider that as a waste clearance mechanism that involves fluid transport through the CSF along the perivascular spaces and the interstitial fluid. And what we are looking for is solute movement through the tissue as this fluid exchange happens. The way to measure lymphatic MRI in people currently involves contrast administration. There is no other way to, there's no other gold standard for it. The gold standard is a contrast administration. And they are, the injections are given intrathecally, not IV intrathecally directly into the CSF space. So they're not very practical to be used to study Alzheimer's disease study risk. So the goal of at our ADRC was to develop non-invasive methods to measure different aspects of lymphatic function. So it could be the CSF flow in the subarachnoid space, in the subarachnoid space. It could be CSF flow along the perivascular spaces, its transport into the interstitium, and then also its exit into the draining sinuses of the meningeal lymphatics. So I will show here a study by Dr. Patrick Fillingham. What he did is he collected MRIs of all different kinds. So he did a T1, a T2 to understand brain structure. He collected angiograms of the arteries and the veins separately. And then he collected blood flow information, CSF flow information. We haven't talked about that imaging modality, but I put a picture here in grayscale, which shows how CSF is flowing on the surface of the brain, through the foramen of Monroe, through the aqueduct of Sylvius. And he combined all of that into a computational fluid dynamics model to see how CSF is flowing in the subarachnoid space and in the ventricles. And this is on a per person basis. If you do all these MRIs, you could get to this model. And what he showed is that the CSF flow in the ventricle, it's definitely not stagnant, but it kind of reverses itself in early systole and early diastole. So I don't know if you can see the arrows, but in the start of systole, the CSF flow is going from front to back. It reverses in early systole. Then it kind of continues that way until early diastole, where it reverses again. And during these two phases, there's also a lot of recirculation of CSF within the ventricle. And changes in these patterns could be tracked in individuals to see if that affects CSF transport and eventually lymphatic transport. What this study also allowed us to do is over a cardiac cycle, it allowed us to look at CSF dynamics. So how is the relative pressure and flow for CSF changing from the top of the brain to the bottom of the brain? So using the foramen Monroe as a reference, what does the pressure of CSF look like in the ventricles, and what does it look like in the subarachnoid space? And here you can see the ventricles is kind of as we expect, it follows the cardiac cycle over the systole and diastole. The subarachnoid space is much more variable over time. And so we hope that we could use this information in the future to really understand solute transport or amyloid accumulation. So this project was started, I believe, 2 or 3 years ago, and this is one of the first results or works coming out of that. It's led by Dr. Fillingham. This is another work that we've done, which is a diffusion-based sequence that looks at the subarachnoid fluid CSF flow. And we ran an experiment in young adults with full sleep and with 24 hours of sleep deprivation. And what we found was that the subarachnoid CSF flow went down in all of them after a night of sleep deprivation. And so this kind of indicates a relationship between sleep and CSF flow. I did not mention that earlier, but lymphatic transport is considered to be sleep active. So it's more prominent during sleep, less during awake stages. So if you do not get sleep, does it affect any component of lymphatics is what we were trying to check here. Oops, I did that. Okay. Another modification we have is a modification to our perfusion sequence, which measures blood flow, and we've seen some examples of that, but it can also measure exchange time. So this is the time that that the blood takes to go from the blood vessel into the tissue compartment. It's essentially water transport because MRI measures water. And so it tells us about the endothelial permeability. It could be blood-brain barrier permeability. It could also include a permeability that's affected by the perivascular spaces right adjacent to the blood vessels. So this is a new modality that we have for you to use at the UW ADRC. What we found is, again, we didn't see too much of a difference between sleep and sleep depth, but what we did see is the change in this parameter was related to cognition after a night of sleep deprivation. So again, we have another parameter that may be sensitive to sleep deprivation and its association with cognitive performance. And then finally, I do want to touch base on 2 more things. This is Dr. Mehmet Kurt's work. He is trying to develop the hardware and the actuator for magnetic resonance elastography. So this is a way to study tissue stiffness, where there's a pillow under the head, and there are vibrations of certain frequency and phase that are sent through this device into that pillow. It's like a massager under your head. And those vibrations then go through the brain tissue. And depending on how they are transmitted, you can measure stiffness of the brain tissue. And there is there are hypotheses that as amyloid deposits, the tissue becomes, or even with tau deposition, the tissue becomes less, it becomes stiffer. And so it's less flexible in other ways. This also happens with cerebrovascular disease. And so Dr. Kurt has been looking at older adults, and he has done studies with controls and MCI participants. And here he shows how the tissue is much more compliant or less stiff in a control participant, and how the compliance goes away in the MCI participant. So this technique, we are trying to get it, I would say, running well on the scanner, so you can also have this as a tool. And Dr. Kurt has agreed to make his apparatus available to anyone who wants to try out MRE. So that's very kind of him. And then this is the Clarity grant that Tom mentioned. The goal of Clarity is to come up with a 10-minute exam card. It's an MRI-based exam card that improves the diagnosis of AD. Now, we already know that AD is only, that MRI is only used to look at hippocampal atrophy. So what are we looking at here? So 2 things. One is, I don't know if you can see the difference in these 2 images, but the image on my left is a normal T1 weighted image. And the image on the right is a volume navigated and motion corrected T1 weighted image. What that means is that a T1 MRI takes about 6 minutes to acquire. And we normally think that people are very still during that time, but there's very minute motion that occurs in the scanner. It's very hard to stay absolutely still. And now we found, especially this work by Dylan Tisdale, shows that this minute motion introduces a lot of variability in the measurements of cortical thickness and hippocampal volumes that you get from the T1. So one goal of Clarity is to use this volume navigated and motion corrected T1 to improve the quality of T1 itself and get more precise cortical thickness parameters and hippocampal volume parameters from that T1. And then the second part is to use a multi-delay ASL approach. So this is not really looking at ATN directly, but it's still trying to get to ATN in some way. So N is coming from the T1 parameters. A and T we cannot measure. Maybe T, if you will, still would be part of T1. The reason for the multi-delay ASL is to look at blood flow, but the difference in the ASL sequence here is it can also help you find the blood volume. So are your vessels fully dilated or not? Are you functioning at maximum reserve or not? Some of those questions now can be answered with this modified ASL sequence. It also tells you a parameter called ATT, arterial transit time. It's an MRI parameter that can be connected to how is the blood flowing slowly or is it flowing fast? So is there cerebrovascular disease or not? Apart from just blood flow, which can be a marker of metabolism. So one sequence that tells you about metabolism, cerebrovascular disease, kind of trying to tease those two apart. And each of these sequences will be about 5 minutes. So in 10 minutes, we'll try to collect as much information as we can about the N marker of AD, and then the vascular comorbidity that's present in Alzheimer's disease so much. So that's where we are going with Clarity. And with that, I just want to end with, I showed so many different MRI techniques and what they're doing, but they're all looking at a very small piece of AD. So it's like looking at the 6 blind men, looking at different aspects of the elephant and thinking that it is this one thing. With the ADRC, we have so many resources, not just MRI, but we do have biomarkers, we have behavioral data. So it's a great place to do the imaging, but take all these other things and put them together to really understand what Alzheimer's is about. And then very briefly, if you want to start an imaging study, Tom already mentioned you could apply to the ADRC pilot projects and talk to the clinical core for cohorts. You could also reach out to me or Tom specifically for imaging needs. You would need to have a project or a grant, an approved IRB number. We have template intake forms for this. So you can fill those forms and we are happy to design the imaging protocol that you need. We are also happy to develop new protocols for you. Anything you need, we can possibly do. We are happy to help you with that. Normally after that, we get you safety trained and then you can start scanning. If you need help with processing of data, then you can also reach us by email. Tom and his group will find the right personnel to do the processing or to train you or your trainees to work with the imaging data and also provide you with computational resources and the right neuroimaging softwares. And at the bottom, I have Tom's email, my email, and the emails to our lab.